doing a review that for all of you to be able to more easily understand and to review those concepts that you need to know. Now, this review is not only good for your exam, it's also good for your HESI. So remember, as you study for your HESI, to go back and look at these reviews, okay? So let me share my screen and let's do the PowerPoint. Now, I'm sure all of you have it. If you don't, please send me a message in the chat box and I'll make sure you get it because I have access to all the classes. Okay. So pediatric, I don't still believe it is exam 2 already. It is already week 6. So again, remember, this is weeks 4, 5, 6. I will be sending out with this review all the Kahoots that I've done in my classes, which really go over those concepts that you need to not only memorize, but to understand and to apply them to different situations. So let's start with cognitive and sensory impairment. Now, in class, we have gone over different sort of eye conditions, amblyopia, strabismus, and nystagmus. So what are these and what do they mean? So amblyopia is that lazy eye. That means one eye sort of hangs to the right or to the left and the muscle's just not strong enough. And you're going to see it very clearly, just like this child in this picture. So what do we do? How do we treat this? Well, the only thing we need to do is strengthen those muscles in the bad eye. So we have to make that bad eye work. So put a patch over the good eye and let that bad eye do its own work. Strabismus is when your eyes, they just don't go together. You have an eye and an eye, and they sort of cross midpoint, which is what we call strabismus. Who was that? Oh, let me see. I found you. Excuse me. All right. So strabismus, as you can see, these kids, they're sort of looking almost cross-eyed. It's because their eyes do not align up well. Now, early cognitive impairment, you know, we can figure out if there's going to be a cognitive delay, if the child looks different, you know, dysmorphic figures. We think of dysmorphic, it could be something like a Down syndrome, or ears wrong, or nose is wrong, or the shape of the faces, and you sort of can figure it out from there. You can also tell, like if you are in a classroom or in a daycare and you see a child, you know, they have cognitive impairment because they're irritable all the time. And it's really for no reason. And even though what's going on around them, they're not paying attention. It doesn't bother them. Okay. You will see that gross motor delay. And remember, gross is get up and go, anything motor. Okay. Fine motor, F for fingers, anything to do with fingers. They can't grasp yet. They can't put a rattle from one hand to the other hand. That could be cognitive delay. Language, I mean, we should start out as an infant cooing. By the end of 1 year, they should be able to say mommy and daddy and sort of get their point across. And if they're not making any words at all, that's a cognitive delay. Behavior difficulties you will see. If you can imagine you can't express yourself and you can't tell your caregiver what you want, you're going to have behavior difficulties because that's the way you get the attention of them. And those normal milestones, turning over, sitting up, creeping, walking, crawling, you're not going to meet them when you should. You're going to be really delayed. So when we're talking about cognitive sensory impairment, we're going to be talking about Down syndrome, like I said. These are beautiful children, probably one of the reasons why I went into nursing. And when I was a teenager, I was teaching them swimming at the YMCA as I got my lifesaver degrees, and absolutely loved the lovability of them. They have these short, stubby fingers and toes. You're going to see that nice little simian crease, which is there for them. In their mouth, their palates are really high. And when you think Downs, most of the time you think of the tongue hanging out, which is because they don't have control of it because it's too big. And then of course, those beautiful little almond eyes. And the one thing about Down's children, they are susceptible to cardiac defects. Most common is that ventricular septal defect, but it could be AV canal and it could be truncus, which don't worry what they are. They're just a congenital defect, very specific to the Down's child. They're also very hypotonic, which means their feet can go behind their back of their head, but got to be careful you don't pop their hip joints out. That's how absolutely flexible and hypotonic that they are. We're going to see the way that they move, that cars, that palmar crease, like I said, and then between the toes, you have a big toe and the next toe, there's going to be a space, which is not usual for normal children that don't have Downs. And then the other thing, they're very susceptible to a lot of upper respiratory infections because their nasal bone is underdeveloped, mucus get caught. What does that happen? It grows bacteria, goes into the ears, cough, etc. So that's one of the things that they're susceptible for. These children who have to be admitted into the hospital, they really have high anxiety because they do not want to be separated from those people they know, their caregiver, their parent. And it's very important, especially on these children, that the parents be able to stay with these children overnight because their stress goes very high and we don't want to do that. So verbal milestones. So what are those things that are appropriate? Well, by 2 months, they should be doing, that single vowel sound. Of course, they're crying, they're cooing, and they're making little noises. By 3 months, they're gurgling and you can start to hear them laughing. If you ever see a little baby at that age laughing, it's just so cute. By 8 months, they're trying to say that mama, dada. They're imitating, which is part of what infants do and what children without cognitive delays do. They imitate what they see and what they hear. By 10 months old, they're going to start saying that no, no, no. And you're like, why are you always saying no? Well, it's the word that they know. So they can just know. And then, of course, they should be saying mama, dada about 10 months old. And by 1 year old, it's 3 to 5 different words. It could be milk. It could be juice. It could be favorite food, maybe the dog, the cat. So different things they can say, but about 3 to 5 words. Now, these children who do not respond and do not talk the way that they should, the first thing that needs to be done is they should be evaluated for potential hearing loss. Because if you can't hear, you don't know that you should be making a sound because you don't hear that sound. So the first thing is to look for hearing. Now, children are born, they get a hearing test, but it doesn't mean that they lose their hearing as they go on. Now, autistic children, these children usually aren't diagnosed till about 2 to 3 years old. We might know before then, but definitely at this age, we're able to evaluate them a lot better. These children do not make good eye contact, and they don't like really to be looking in your eyes. They're always looking away. If they're somewhere playing in a corner, they are not going to respond to their name. They get so absorbed in what they're doing. And what they do is these repetitive behaviors, as in if they have a block and they have a chair and they have a truck, they'll put the block up, they'll put the truck on top of the block, then they'll put the block in the truck, and they'll put a thing on top, and they'll take the thing off top, put the block out of the truck, put the truck down, repeat, repeat, repeat. I've watched autistic children do this thing over and over 20, 30 times. It just gives them comfort. That's why they do it. And they're not going to do any imitation other kids are doing. They're not going to try to speak like them. They're not going to try to play like next to parallel play, one playing and the other one playing the same thing, looking what each other's doing. They're not going to do that. Also, they're not going to be able to verbalize what they need. They're not going to have all those words, those 4 to 5 words of a 1-year-old. They're not going to know those words. They're not going to be able to express themselves. Also, there will be motor delays. It could be as infancy we see it, or it could be, not turning over, not walking till quite late. Or it could be as they get older, they're not, still being very unsettled on their feet and not as, graceful as they should be, and they're falling more. These things that you will see with those motor delays. And again, they don't like to play with other kids. They want to be alone. They also don't like, some kids don't like slimy things in the mouth, or they don't like things, that has lumps in it, depending, is this textures, they don't like them. And they do not like loud noises and bright lights. They really need that quiet, calm, darkened room, sitting in the corner, playing, doing repetitive behaviors. That's what they like. Now, immunization. So you have a kid who's on cancer. You have an immunosuppressed child. It doesn't matter. We can use this and expand it even more into immunosuppressed adults. And you could be immunosuppressed just by getting steroids, because steroids make you immunosuppressed. So if you have a child, or even adults, because I know you're all in med-surg too, also are going to be. So you cannot give them a live vaccine, okay? Now, family members can get it, but any child or adult that's immunosuppressed, getting chemo or on prednisone or another immunosuppressive disease, do not give them a live vaccine, and that's a very important thing. So how do we educate parents about making sure that they get immunized, and what are we going to teach them? Now, we know that there was this research study that came out and said it causes autism. Well, they did find out that research was false, and they did show that physician that he was wrong in publishing it, and that physician doesn't practice anymore. It was that chickenpox vaccine at the age of 2 to 3 when we diagnosed them. And that's where that came about. So taking and having the parents understand that is very important, that there is no reason why they shouldn't be immunized, because it prevents bad diseases. So at birth, most infants get their first Hep B vaccine. If not, it'll be the first visit, but we like to give it in the hospital before they leave. So we know that there are some parents, and I've worked in an emergency room where, say they're not vaccinated, you ask why. And I've heard all of these reasons: religious beliefs, personal beliefs, safety concerns, or they just want more information. So we need to respect those who don't want to get vaccines, but we need to protect ourselves, and we need to protect other children in our care. So family-centered care and stress of that child during hospitalization. So you have a kid who needs to go into the hospital. You've got parents who need to work, who have other children and other obligations. So it is a very difficult time for the entire family. So those children who have chronic or disabilities are going to need frequent hospitalizations. Could be cystic fibrosis, could be sickle cell. These are the ones that are going to have the most stress, because maybe something happened that unnerved them at a previous hospitalization. Could be they had pain, or the nurse didn't explain, or something that, set them to be afraid now of the hospital. So because of separation anxiety, we should always leave a parent with them in the room, so that they can be there to calm them. Not a parent, a grandparent, caregiver, whoever keeps them comfortable, they should be allowed to be there. So we know this separation anxiety, if they need to leave, we know these children are going to be difficult. They're going to be crying, and they're going to be fighting against us. We know that males tend to be that more aggressive no than females, and we know that this separation anxiety starts at a young age till about 6 years old. And if a child is cognitively impaired, they don't understand what's going on, so they get extremely difficult to handle. So skincare in the hospital, we think that only adults have problems with skin and worrying about turning, positioning, and decubitus ulcers. Well, children can also get these breakdowns also. So number one on the list of preventing skincare breakdown is good nutrition. Nutrition is the most important thing we can give our children. Also, if we are on bed rest and we cannot move, the child can't move by themselves, use a draw sheet so that we're not sliding them on the bed and creating that shear and those ripping of skins, because it could. Keep their skin nice and moist, have that little moisture reduction pad, or if it's a child, we can put a diaper on them and turn them every 2 hours. If we have a nice bed that has air in it, that's moving air, those are the best things that we can have, types of beds. So children do have hip bones, they have knees and shoulders and elbows. Make sure that we do, rub them and turn them and prevent those skin breakdowns. So care of a child during hospitalization. We're going to get a child in, and the first thing we have to do is do an assessment. So how are we going to do an assessment on a child? Well, I think that get the kid comfortable. Well, put them in the parent's lap, usually. In fact, that was my dissertation about help us give great injections efficiently and safely, Huggies. And it was about putting the child in the lap of the parents, because I proved through research that the stress was a lot less on those children. So that's number one. But the next thing we need to do is to get on the level of the child. Speak to the child in terms that they understand. And those toddlers, play, and let them touch all the equipment. So during hospitalization, these children sometimes cannot express what their needs are. So we can do these expressive activities through play. And this can help express emotions. So if you are playing on something and you're really beating it up, or, if you had bean bags and you're really throwing it and you're pounding on that, bean bags or the pounding bags hard, something's going on, and that might be helpful for you to break the ice to speak to that child. Also, dramatic play is a well-organized technique for emotional release. Maybe something happened to that child that they don't know how to tell you, but through dolls and stuffed animals, etc., they can reenact it, and it's very non-threatening. So it can help the child express themselves and us as nurses to understand what they're trying to say. And then also that creative, that writing, the painting, making things out of stuff, that creative thing, again, also helps them with feeling. But dramatic play is the organized one that you can really tell what's happening. So whenever we're working with children, think about they're going to be in pain, okay? Pain is one of those priorities, and children are not going to tell you. They're not going to tell you that it hurts because they don't want that shot. They don't want that shot for pain. They'd rather deal with the pain. So again, if they're in pain, make sure you know when the last doses were. And if it's time, just like an adult, you don't want to wait too long because nothing will work. Also do that. Also turning, positioning, head elevated, head of bed, all the extra pillows, all those things we can use as long as it's not contraindicated. Now, what if you have a child who just had, let's say, abdominal surgery or cardiac surgery, and they need to do that coughing and that deep breathing? Well, you're not going to do that unless you've medicated for that pain, right? So once you medicate for pain, then you can get them up out of bed. They can use, instead of spirometry, they can cough, deep breathe. They can use that pillow, splint for the cough. So medicating for pain, it benefits the child, in many ways, circulation and for those lungs also. Now, Tylenol, acetaminophen, is the only thing we use for pain or fever on infants up to the first 6 months. After 6 months, we will order and give you the ibuprofen, pediaprofen, Motrin, Advil, whatever you want to call it. Then we can add it and we can alternate that for Tylenol and ibuprofen for fever or pain. Aspirin, no, we do not give it. The only time is Kawasaki disease that prevents the clots and that vascularitis. But if we give aspirin, the chances of Raynaud's syndrome go up. So we don't want that. And again, our goal is not just morphine. It could be Tylenol and ibuprofen. combined in there, and that can help with pain. So you have an IV. It's very important to assess it every hour. I mean, if you look at that kid's arm, that forearm is really swollen, but maybe that's the fat roll. Well, we're going to look at it, touch it, see if it's still soft, if it's red, if it's got a streak, is there pains, is there leakage, blood? And if it does, we're immediately, the first thing we do, priority, stop that infusion. Now, we need to call the physician on some sort of IVs because sometimes they want to inject some sort of medicine that will help prevent necrosis of tissue, especially for things like dopamine and epinephrine. We want to give that Regitine to dilate the vessel so we don't have that necrosis. But what do we do with it? We're going to stop it if we need to. That's the first thing. And then we are going to tell the physician, he says, go ahead, take it out. We're going to remove it, put a nice warm pack on there and elevate it, and then restart a new IV. Better safe than sorry. Now, children have gastrostomy tubes just like adults do. So if we look at these are two types. We have the button on the right, or a MIC, whatever you want to call it, and then the one that just looks like a Foley catheter hanging out. They are both good choices, and they're both put in for different reasons. So how do we take care of these? Well, all we do is once a day, soap and water. Research proved that that was the best thing to do. We used to do all different other stuff, but we found that soap and water was the best for the integrity of the tube and the skin and etc. Now, children need oxygen for many different reasons. You know, they've got pneumonias and they're not oxygenating well, or they're cardiac and they're not oxygenating well. So if I needed to give on a little itsy bitsy baby, what would I give to the child best tolerated? Is that little oxy hood. And if you notice, it's clear and they can look around and they still can put their hands underneath and suck on their fingers and have a pacifier. It's really good. The next thing that I would choose is a nasal cannula. It's just a little tape though, and the kids do put their fingers and they do rip off the tape and have the oxygen in their hands sometimes. The least tolerated would either be that continuous pressure, also called CPAP, or a ventilator. Both of them are more difficult to tolerate it. So oxyhood is the best. Now, oxygen via nasal cannula, we can show how much oxygen is being delivered. I mean, some children don't even need but 22%. So we have the ability to go down to a quarter liter, a half a liter. So we would get a little bit less of that oxygen. But depending on the flow, this is what the percentage is of oxygen. So you have an infant complaining of fevers, has smelly urine, and we need to get a specimen for them. So the best way to collect urine on an infant is to catheterize them. Straight cath, just to go in, clean it well, go in and get the urine. And now we have a really good specimen that we can check for whatever bacteria is growing. I know that the parents think that they're going to lose their virginity, and oh my goodness, if it's a male patient, the fathers are cringing. And I say, listen, I know how you're feeling. It's uncomfortable, but it doesn't hurt. And we can even tell them that we're using lidocaine jelly so that they don't even feel it. So there's ways to express to the parents that they will help you. Hold that child's hands as we're going to do the catheterization, because we need that distraction there. So intake and output. So how do we know what do we count for each? Well, if it's intake, anything taken by mouth, anything orally, we're going to count, and anything IV. Now, sometimes as we're given IV medicines, we're flushing before and after. If this is a patient like a cardiac and congestive failure, I want to know every little ml/cc that's going into this child. I'll record all of those flushes. Now, output, we have urine. Now, how do we go ahead and measure urine on a infant who has a diaper on? Well, if we have a dry diaper and it weighs, number one is 30 grams. So if we take it off the child, it's wet, and it's now 60, it weighs 60 grams, we know 30 minus 60 is 30. Urine output is 30. And that's how simple that is. Recording the stools, estimating vomit, fistulas, NG tube suction, it usually goes into the canister. We can get that. And we can really, if we need to, we can weigh chucks or linen if we have to, if there's that much drainage going on and we need it that accurate. So giving medicines, some children, not a problem. They're easy, you put it in their mouth and they, have no problem. And actually they're trying to suck on the syringe when they're done. There are other children whose mouth is closed, they're screaming, their head's turned the other way, and it's really difficult. So if you take the child and have the infant, hold their arms and you have their face in front of you, put the syringe in the side of the mouth and slowly you could put the medicine in. Another thing that I teach parents is that put the medicine in and do a quick blow in their face and they just jump and swallow, and that actually gets the medicine down too. It's a trick. So during hospitalization, we know it's a hard time, and we talked about separation anxiety, but there is regression that goes on there. They want to be nurtured and loved and hugged, and they regress, maybe sucking their thumb, or maybe a younger child wants a pacifier or a bottle back. These are things that do happen. It's their response to hospitalization. So this relieves stress. So there's nothing wrong with it at this time. So children, as I said, it's a lot of self-soothing. We talked about infants, and infants, it's the pacifier, oral, anything in the mouth, and that will help. Another thing is, because this is such a stressful situation and they're regressing, let those children touch and play with the instruments. Let them take the blood pressure on you before they take it on themselves, or push that electric button if that's what you're using, because this is a stress relieving thing that we do for children. And remember, the highest level of stress, the greatest stressor, comes from, especially those preschool children, 3 to 5, is that separation from the parents. They know that their parents, that they had to leave, and now they're going to get really angry if they're not there, and really afraid. So the greatest stressor is that separation. One of the things that can help, especially when you're talking about toddlers, toddlers like routine, they like same things going on, and even preschoolers, but they tolerate it a little bit more. Keep them on the same routine. They wake up in the morning, they go in the bathroom, they brush their teeth, and they get dressed for the day. Do the same thing in the hospital, or change their pajamas into new jammies, whatever. Then, try to keep the same sort of foods that they're eating. Also, if they're, in school and you've got the schoolwork and they are able to, have them do that schoolwork together. And naps, nap time, same thing. And as long as the nurse knows what the parent is doing, we can work around the parent and the child's schedule to make sure that they keep on that same routine. Now, drawing blood from an infant can be very easy, okay? We do heel sticks on them. And what we do is the sides of the heels. We never get in the middle. And how do we do this the easiest and least painful for these children? Well, when we use a hospital-approved heel warmer and we put it on the foot and warm it up, the foot vessels dilate, right? So now we hold the leg down and we pinch it with a little lancet, and with those little tiny tubes, we can collect the amount of labs that we do need. Okay, so hospital approved heel warmer, and slightly squeeze the heel, not a lot, and you can't squeeze it tight, but slight, and the blood flows out really nicely. So again, talking about children and talking about parents, I can't stress enough that these children should have the parents, at bedside if they are allowed, because it does decrease stress. Also, it also allows the parents to be involved in the day-to-day goings on in the hospital, learning maybe what they need to do at home. And it could be in that supervised area where you're watching the parents perform a task that the child's going to go home on. So chronic otitis media, there is these little short canals and children, big adenoids and tonsils and mucus sits there and it goes up in their ears. And it is a bacteria. I mean, you always have staph in your oral pharyngeal airway. You do. It's just what we have. But it gets pretty bad when it all blocks up and it doesn't drain. Your ears, I mean, I've seen them oozing that much. It could be the eardrum is popped and now all of that pus is coming out. So how do we treat these? Well, again, pain. These hurt a lot. Tylenol, acetaminophen or ibuprofen should be given. Also, they're going to be placed on antibiotics by mouth, and sometimes it's the outer canal. We'll do antibiotic drops for that. And if these things are chronically occurring, multiple ear infections, we're going to be putting tubes in there to keep that open. So our goal is to prevent hearing loss because of these multiple chronic ear infections, and to keep this child from hurting. Always, pain is a big thing with children. Make sure they don't hurt. Now, one of the respiratory conditions is called bronchitis. If you've ever had bronchitis, you go to the doctor, they order you a Z-Pak and they order you cough medicine. This is this terrible cough, and you feel it especially at night when you try to sleep, and it's non-productive. So non-productive, dry, hacking cough that's worse at night. You lay down to go to sleep and you're coughing. So you take cough medicine and hopefully it'll knock you out. So we treat the symptoms here, and it's mostly the cough. Asthma. Asthma is a childhood condition that something gets in the lungs and tickles the lungs, some antigen, and creates bronchospasm, swelling of the bronchus and the trachea, and creating a smaller airway. So what does that cause? Well, cough. You're going to have difficulty breathing, chest pain, and then you're going to hear wheezing. The other thing is a prolonged expiratory phase, because air goes in easy, but then in all that swelling, it gets caught. So it's hard to come back out. So how do we treat it? Well, we're going to be treating it with, a rescue initially. And it could be with an MDI, that little puffer machine. Now, one of the things that you need to be sure of is you get a child into the doctor's office or emergency room, and they've been using their rescue for 2 days and it's getting worse. Find out how they're administering it. I wouldn't know myself sometimes. Take a puff and inhale at the same time. It's really hard to do. And small children, they can't do it. So they're puffing it and it's going nowhere unless they use the spacer. So make sure that these smaller children do have a spacer, and it will be more effective. So what is asthma? It's a chronic non-productive cough with diffuse expiratory wheezing, and you're not going to see a child with a fever because it's all just swelling in the airway. Cystic fibrosis is a autosomal recessive trait that 1 in 4 chance of getting the disease if both parents have it. Many times we don't know a child's going to be a cystic fibrosis. Parents don't know sometimes they have traits. And then at birth, we do not see this child having a stool within the first 2-3 days after birth. This is one of the diseases we're going to go looking for. It could be hypothyroidism. It could be cystic fibrosis. So how do we go and how do we test this child? Well, it is called a sweat test. So they're constipated. Let's go ahead. Let's test them. We're going to be doing a sweat test. And we are going to do that metabolic screening just to be sure also. So what do you see? You've been diagnosed, you have cystic fibrosis. It is mucus that clogs the lungs and the small intestines. It is the inability to break down food. And then you have these large, foul smelling stools. You have the inability of breaking down fatty vitamins and absorbing them. So you're going to have deficiencies in these fat soluble vitamins A, D, E, and K. You're not getting vitamins, you're not getting nutrition, you're going to lose weight. Now, because of all of the secretions up in the lungs, I call it like a petri dish, a thick clogging of mucus, and bacteria loves to grow there. So you're going to have this cough, cough going on. This child needs absolute, the best respiratory care that we can possibly give them. CPTs, we're going to be giving them aerosols, even antibiotic aerosols to try to clear them up. Now, as I said, a lot of it has to do with diet, and they're not absorbing what they need. So these children need high calorie, high protein, and they do need salt because they are secreting it out their skin. So they do need that. They do need some sort of vitamin supplements so they can help with those replacement of those fat solubles. Also, as I said, those lungs, they'll be on saline and bronchodilators, and they'll even be on antibiotic aerosols to help the lungs move. As I said, aggressive physical therapy, be chest PT, cupping, percussion, postural drainage. They'll be doing this peak expiratory pressures, and they'll have that vest on and really, massaging that chest to keep those secretions movable and getting them out because they are thick and they clog. And if you don't have space in your lungs, you're not going to breathe. So what do we do besides this chest physical therapy on cystic fibrosis? We're going to be giving them pancreatase enzymes about 30 minutes before meals or snacks. And this helps them digest their food better. Of course, in any medications, you don't chew or crush any enteric-coated beads. There's going to be another choice for you. Now, if you have those capsules, sometimes children can't swallow them, but we can open them and sprinkle the beads on the food. Or sometimes we use a powder, but just make sure we rinse the mouth when they're done. And the one thing I think we forget as professionals is to check the dose for now, what's the weight, because children are growing, they're always growing. Is the child need a new dose as they are bigger than now? And that will help also with nutrition. So, long-term outcomes. Long-term outcomes for cystic fibrosis patients. Well, children, males who are adults, if they are with cystic fibrosis, they're going to be infertile. They're not going to be able to have children. But if they go and get that double lung transplant, which many older cystic fibrosis children decide to do, after 1 year, they're going to be able to have children. And I think that's awesome, going from not having the ability to having the ability to have a child if they want to. Tonsils. Well, many children, adenoids, tonsils, tubes, this is something, that is a very routine procedure for children. They go in the morning and usually out by the afternoon and they're sent home. So what are we going to do to teach parents? Very important teachings. Well, they shouldn't have any irritating or high seasoned food. It's going to burn where they cut out those tonsils. They're going to be quieter. They're going to be rest. They should be drinking fluids because they still need the soothing fluids, whether they like warm, but cold is actually the best thing because it sort of numbs it. Putting an ice bag, an ice collar on, keeping that area cool. Popsicles, but don't use red ones. We want to make sure it's not a red popsicle that it's not blood, okay? So any other color, but not red right now. And then the other thing that can be done is older children get tonsillectomies, and their ears tend to hurt after tonsillectomies, so they chew gum, and that helps with the pain that's going on there. And one side effect that we watch for is if a child's sitting there and they're swallowing, we need to know to look in that mouth, which we usually wouldn't do, but we're going to see them bleeding. And that's when they get back to the physician or to the hospital to check on that bleeding to make sure it's not too much. Now, children have a lot of upper respiratory infections. Have you ever taken Afrin or 4-way neosynephrine nose spray? And because at night you're breathing, your mouth's open because your nose is so full, and your mouth is so dry, you just want to breathe through your nose. So you use these, airway decongestants up the nose to try. Well, problem is, if we use these, sprays for decongestant more than 3 days in a row, once you stop, it's going to be worse than when you started. So please teach our patients, our parents, not to use it more than 3 days in a row, because then they will take even longer to be able to breathe normally from their nose. Epiglottitis. Epiglottitis, well, what is an epiglottis? Well, the epiglottis is that leaf-like structure that covers the trachea when we swallow to prevent food from going into the lungs. Well, what happens in epiglottitis is we have croup and we have a barking cough, and you sound like a seal, barking, barking, barking. And if we just continue, that irritation in the oral pharynx gets worse, the swelling gets more, the epiglottis gets more swollen, and it covers it, and now we cannot breathe, and it's a medical emergency. Now, when you see a child with epiglottitis, remember that piece of skin is covering their larynx. So how is air getting in? So these children are going to lean forward a little bit to the right, left. They're just trying to find that little piece of air they can get air in there. This child is going to be drooling, because they can't swallow. They can barely breathe, and they're going to have a mumbled speech because they can't talk because the swelling that's going on back there. So you're going to see them leaning forward, you're going to see this drooling, and you're going to hear that garbled talk on these children. Never, never, ever look in the back of this throat, because what you're going to do is create more swelling, unless you're that person who's going to intubate or do a tracheostomy on that child. So common croup, as I said, common croup is a barking cough. We need to treat it because we don't want to go to the point of epiglottitis. Now, these are usually a viral thing. It's 6 months to 3 years. You'll have that little low-grade fever, usually 100, maybe 101, and they're going to be barking and barking. And you are going to be seeing a little bit of respiratory distress. You will see it go to the point, if they start with that inspiratory stridor, again, we're getting close to epiglottitis again, get in for emergency treatment. How do we treat common croup? We give them a steroid, whether it's one shot, whether it is, oral medicine. Patient condition is what it depends on. Is the patient alert and talking to me, or coughing so much they can't swallow? So whether it's oral or by an injection, they'll be getting a steroid. Now, respiratory syncytial virus is just that, a virus. For me and you, it's a common cold. But for some small infants with little airways who have a hard time just sucking, swallowing, and breathing, just eating a bottle or breast is a lot of effort for a small infant. Now, put a little bit of mucus in the airway and a little fever, these children are unable to eat, they're unable to drink. So it usually happens between the winter and early spring. And these illnesses can be just treated maybe with some suctioning and maybe aerosols with just saline to loosen it. And sometimes we can do that. But what if you are a child who's premature? Or what if you are a child who has a cardiac condition or cystic fibrosis? We don't want this kid to get it because this can be very dangerous. So what do? We're going to be given a monthly, every month from like September to May, we're going to be given a immunization called Synagist. It is Pavivsmubab, and it's every month for those months. And it helps prevent those children who are at risk for getting respiratory syncytial virus. Now, RSV is also, the other name is called bronchiolitis. You're going to hear those words interchange. Bronchiolitis, RSV, think of the same thing. So we treat it aerosol suctioning and then giving them time to eat. And then we're going to be on those immunosuppressed, be given those monthly immunizations. Now, mononucleosis is, a disease that people say, oh, it's just a kissing disease. It is a virus, the Epstein-Barr virus. And what you sort of present with is this sore throat, fever, rash, tired, don't feel too good. You might feel that swollen spleen, you may or may not. Now, once we go through the process of finally figuring out that it is a mono, which is done by a lab test, and we find monospot test positive, we need to teach these parents and these children something that's very important. My students know that I tell them about the story about this 9-year-old boy came in after a long trying to figure out what it was, found out he had mononucleosis. We taught the parent, the father, and we taught the child, do not go into PE. You need to get re-cleared through your physician before you can. And please be careful of the abdomen, no sports, no rough play, protect the abdomen because the spleen is swollen. And if you had too much injury in the abdomen, it could burst. 1 month, 1 month. 1 week later, he was rescued in, and I was primary nurse for the trauma team that day. And he came to our hospital. He was out on a trike in the middle of the Everglades, fell off, hit his abdomen, and yes, his spleen burst, and he arrived dead on arrival. So mononucleosis, yes, is a kissing disease, but please tell them, protect that abdomen. It is a virus. We treat it with fluids, rest, Tylenol, and Motrin, and it does take a couple weeks to go away. Tetralogy of Fallot, cardiac condition. Remember, it's all right-sided. You're going to have a hole between those two chambers, right and left side. You're going to have that pulmonary artery, which comes out of the right ventricle up into the lungs. It's going to have some either narrowing or a tissue that just piles over it and stops, like putting a hand on it, a cork on the pulmonary artery. Blood can't go up to the lungs. And then because it gets covered sometimes in a TET spell, that right ventricle gets stretched. That's why right ventricular hypertrophy, and the aorta is just moved over a little bit. That's what those things mean. So if you ever have to guess what's tetralogy, where is it? Think all right side of the heart. So you need to know your anatomy. So infants with TET spells, what do they look like? Well, I had an infant. I was changing the diaper, doing a little tiny little wash the face thing, and the kid went blue. Sats of 100, 10 seconds later, they were 10. What do? You take that knees and put it up to the chest. It's called a knee chest. And what does that do? It changes the pressure between the abdominal cavity and the chest cavity, and poof, and hopefully it will pop open that area that's covering the pulmonary artery and allow blood to reflow up there. Now, older children who have tetralogy, who have not been repaired, it's pretty neat. They feel this coming on and they squat, just like that little boy up there. They go right into a squatting position, and it does the same thing as that knee chest. Yes, the tetralogy does need repair, but of course that's according to what the physician says and when it should be repaired. So we have congenital heart defects, things you need to understand. We have increased pulmonary blood flow. We have ASD, VSD. Why is it increased? Well, If there is high flow on the left side, you've got 4 veins going to the left side, and you just get that blood back from the body going into the right side. So it's really low pressure here. So what you're going to see is blood comes back from the lungs, goes through the septum, either in the atrium or ventricle, goes back to the right side. Well, where does the right side go? Up the pulmonary artery, back into the lungs. Therefore, increased pulmonary blood flow. Also, patent ductus arteriosus. It's fetal circulation. Fetal circulation connects the pulmonary artery to the aorta. So you have the aorta pumping blood up through the aorta, that left ventricle just really pumping it, and the pressure's high and it goes up into the lungs. Increased pulmonary blood flow. Obstruction, coarctation of the aorta, kink in the hose coming off the left side of the heart, the kink. And what happens is blood can't go down, so it goes back, and it usually goes back up into the lungs, and it causes congestive failure. How would you know you have coarctation of the aorta? Well, as an infant, if you caught them, you would see decreased pulses or no pulses in the lower extremities. And you are going to look that there's decreased blood flow going there. Therefore, your blood pressure is lower on the bottom. And because the blood's going up more, you have increased blood pressure in the upper extremities. Once we see no pulses in the lower extremities, if we go ahead and we do a 4-extremity blood pressure, we're going to see those blood pressures lower on the bottom and higher up top. And that's why we do 4 extremities. Now, if the kid is older and it hasn't been diagnosed, sometimes we're going to see the kid, because the extra flow going up those 3 connectors off the aorta arch goes to the upper and to the head, we're going to see headaches and nosebleeds, and that's going to make us start looking. We just went over tetralogy of Fallot, and then decreased pulmonary blood flow, tricuspid atresia. Well, what is an atresia? It means A, without. That means no opening. Well, where is the tricuspid valve? It's between the right atrium and right ventricle. So how is the pulmonary artery, which goes into that right ventricle, how's blood going there? Well, it's not. And then we have transposition of the great arteries. And that just means the aorta and the pulmonary artery have switched places. And in this case, we are going to need to keep that patent ductus arterius open to connect blood from the lungs and to the body systemically, to keep the oxygenation going. How do we keep a patent ductus arteriosus open? We keep it open by what they naturally have, but after birth stops. It's called the hormone prostaglandins. It's synthetic, and we keep it open. Now, what if we wanted to close it because we don't need it open anymore? Well, we can give, it's an NSAID called indomethacin, and that blocks prostaglandin from being made, and therefore it closes up, and that will close. Now, how do you know a kid has a congenital heart defect? Well, I just told you about pulses. That is that coarctation, and one of the things that we do check for. But if you see heart rate up, rapid breathing, swelling, even blueness, you are going to say something's going on here. We also going to see the child tiring out easily. And why does a child tire out easily? Well, if they have a congenital heart defect that's not allowing good oxygenation, they don't have the oxygen for the energy to breathe to be able to feed. So that's why they have respiratory distress, and why they're not eating, and why these children are usually very small. They're burning calories, and then they're not getting enough replaced. Also, you're going to be feeling murmurs, hearing murmurs. Sometimes you could touch a chest and feel the buzzing in the chest from the murmurs, machine-like murmurs you're going to hear with a PDA. And then, of course, the pulses, like I've told you, decreased in the lower extremities, coarctation. Now, Transposition of the great artery, as I said, they're switched. And what happens is we want to keep, as I said, that PDA open. And that is the connection between the aorta and the pulmonary artery. So now, instead of having just blue blood and red blood, now we're going to be able to meet it. And what's the great thing about using this patent ductus arteriosus is just giving this prostaglandin slow, continuous IV drip. It can make us give us time to plan for surgery. It does not have to be a rushed thing. So the prostaglandin keeps it open, and it helps with cardiac output, and it helps prevent any problems with the central nervous system. Tricuspid atresia, like I said in that big chart, what is it? Well, if you look at the picture, there's absolutely no connection between the right atrium and the right ventricle. Therefore, it is it's just an absence of the tricuspid atresia. Remember, atresia is a without, and stenosis is a narrowing. Whether it's aortic stenosis, pulmonic stenosis, those are narrowings. Now, postoperatively, cardiac children will come back 1, 2, 3, 4 chest tubes. It just depends, on the surgery. And these do have to be removed. Some of these children go through multiple stage surgeries, and they're going to be getting their surgeries done at ages 3 and 4 years old. So we need to teach these children what's happening. So it is frightening. So number one, teach these children what's going to go on. Be honest. You will give them pain medicine, but it's going to burn for a second and then it goes away. Also, because it's chest tube, elevate the head of their bed, okay? So we'll teach them, we're gonna medicate them with pain medicine because we don't want it to hurt. We're gonna elevate the head of the bed. And again, document before and after, if they accepted, the teaching, if they understood, and then how they did with the procedure. Now, transplant sometimes can happen. Hypoplastic left hearts is the worst of all of cardiac congenital heart defects. That left ventricle is just a big muscle. It doesn't work, minimal opening, and multiple surgeries have to be done to get blood flow going around to the body. Many of those hearts fail, and a lot of them need heart transplants. Rejection is the greatest thing that can happen for death. So rejection is what we're going to be looking for. It's the greatest risk that they have. Infections are risk, but the biggest is that body is going to reject it. And these children will be on anti-rejection medications for the rest of their life. That patent ductus arteriosus, we've talked about it a little bit. Here's a nice picture of it. We can see it connects the aorta to the pulmonary artery. And we do leave that open for many conditions that need it. And what we hear is this big murmur that goes on with these children. These children there's a couple things that you will see. You'll hear that murmur going on. You also are going to see their blood pressure is what we call a wide pulse pressure. Now, if we looked at that sheet that we handed out on vital signs, we saw that a normal blood pressure is 60/40 for a newborn, even with congenital heart defect. An infant born with congenital heart defect with a patent ductus arteriosus might have 60/18. That's a wide pulse pressure. So when we need to close it, giving that indomethacin, we are going to, number one, stop hearing this big murmur. And number two, our blood pressure is going to go back to where it should. Rheumatic fever. Well, rheumatic fever is due to what? It is due to an undertreated strep throat infection or scarlet fever. And what do we see? Fever, joint pain, rash on the back, subcutaneous joint nodules, And the worst thing is that heart valve damage. Once the heart valve is damaged, you cannot reverse that. And then chorea, that means not walking and shuffling gait going on there. Everything else can be reversed, but not that heart valve damage. So our treatment, well, we didn't treat the strep the first time, so now you're going to be treating it for at least a month. And we will continue to give those antibiotics until all those symptoms go away. And as I said, that heart valve is something that is permanent. Now, infants do get almost every single medicine that an adult gets. I can't think of any cardiac medicine they don't, that adults. We give mics per kilo, milligrams per kilogram. So giving digoxin to an adult, we're going to measure heart rate. And if they're vomiting or see little yellow spots, okay, now we can think it's digoxin toxicity. But with an infant, what are we going to see? Well, we might just see retching and vomiting, okay? Or arrhythmias, you might see those. Are you going to see a decreased heart rate, nausea, vomiting? Now, in the adults, they're going to show you more. But if I see an infant on digoxin, heart rate could be at 100, which is about right there, but they're vomiting, I'm not giving digoxin. I'm going to hold it, call the doctor, get a digoxin level, and just be safe rather than sorry. Now, children, once we do an echocardiogram and we find out there's a cardiac defect, you're going to start planning immediately for a cardiac catheterization. And the cardiac catheterization goes in and really looks at the heart and the pressures and the anatomy and helps the surgeon determine what he needs to do to save, to fix this heart for this child. So when we get this child back from cardiac catheterization, number one priority, check that pressure dressing. Should be on the right groin. And they put in 2 big catheters usually into the femoral artery and the febrile vein. And what they do after they're done with the cardiac cath, they hold pressure there and they make a clot. It stops bleeding. They put a pressure dressing on it, but they come back to the room. You know, they could have jostled the clot. It could have fallen off between moving them from bed to bed or even moving them down the hallway in their crib, etc. So number one, you're going to check that dressing. They can bleed out all their blood in 5 minutes. That's how big these holes can be. So be careful there. Check it first. Then you're going to check the pulses and you're going to document it. Probably decreased a little bit because of those catheters that were in there, and that's okay. And we're going to document the temperature and color of the pulse and do vital signs as we need to. Now, we're going to continue hydration, IV, or if they're awake and alert, you know, give them something orally. You know, they want a popsicle, they want juice, go ahead. It's actually very good for them. And also, the one thing we monitor is blood glucose. It could be elevated because they've gotten dextrose IV, or it could be low because they only gave saline. So monitoring a blood glucose on admission can really, you know, set you up. What do you need to do first? Hematological and immunological dysfunction. It's a lot about this week's information. So when we're talking about hemorrhagic disorders, you're going to see different things. You're going to see thrombocytopenia. You know, when we think of P, it's all about platelets, okay? Decreased platelets. And if you see those legs, that purpura, that purple sort of rash, that is typically thrombocytopenia. You're going to see them bruising. You're going to see them brushing teeth and they're going to bleeding from their gums. And what you're going to see is platelets that just don't work in some of these. Some of these, the idiopathic thrombocytopenia purpura, ITP, is one of those conditions where you have that low platelet count. And it's usually following an upper respiratory infection. So you will see them in low platelets and we're going to be treating them. And many times we can turn it around and make it an acute stage. If it's there for more than a year, it's going to be chronic. So how do we treat this idiopathic thrombocytopenia purpura? ITP, when you think of P, think decreased platelets. So what are we going to do is give IVIG, and we're going to be given anti-D. Also, with this anti-D therapy, we're going to give it between the ages here, and we're good. All of these are the criteria to giving it, but it's just given anti-D, IVIG, and sometimes we need to give some corticosteroids with this. You know, if we're in a hospital, what are we going to be watching with ITP? Well, I want to know what the platelet count is, right? If we're doing daily CBCs, I want to see what it is. So monitoring CBC also. So HIV and children, you know, mothers are born, have children, infants that are born, you know, when they're HIV positive. Now, there is some good heart therapy that mothers can start at 22 weeks of pregnancy. And then immediately after birth, our goal for that infant is to improve their immune function. And we do that by giving these antiretroviral drugs and antiviral drugs. If you have a child born from an HIV mom, it does not mean that child is going to convert to HIV. I've actually seen triplets where 2 were not HIV, 1 was, okay? And our goal is to prevent those opportunistic infections. Probably the biggest of all is pneumocystic pneumonia, PCP, you know, and that affects your respiratory system. And then, of course, there's always yeast. So how do you get HIV? Well, you know, the adolescents, you know, it could be rape, it could be, you know, drug use, all of those things can cause it. And then, of course, the HIV mom. As I said, there is, you know, yeast infection, candida, esophagitis, and they give medicines for that, the nystatin, just like we would. But the respiratory, pneumocystic, the GI is candida. And then, you know, we will see those rashes of Kaposi sarcoma, you know, that can form also. But, you know, our infants, we just want to get their immune system boosted so they can fight and not get it. Now, anemia. Anemia, the most common is iron deficient anemia, and it means that your dietary intake is not getting enough iron. So what do? Well, we can change the diet, or we can give medication orally, or sometimes we have to give that iron dextran, and we give it deep IM Z-Track. And why Z-Track? Well, iron dextran is dark brown orange, stained skin, number 1. And number 2, it burns. So we want to give it deep IM so the medication stays inside where we're giving that IM injection. So anemia. Children are fatigued. Why? It's because if you have low hemoglobin hematocrit, low RBCs, you don't have enough oxygen in your body, and you're going to tire out easily. So these children will need frequent rest breaks, and it's because they don't have the cells to carry that oxygen. Megaplastic anemia, same thing as B12 intrinsic. It just means something's going on and they're not absorbing B12. So they're not making their red blood cells the way they should. And then there's hemolytic anemia, which could be due to some sort of medications that can be given. There's one H6P something, it was in a pharmacology in the very beginning, where they couldn't take medicines with glucose in it because it would cause this hemolysis of their red blood cells. Now, anemia, you know, okay, so you can't give medications, can't change diet. Their levels are so low, we need to give blood. So if you're giving blood and we're seeing something like shortness of breath, jugular vein distension, dry cough, what do we do first? Well, we're going to stop that infusion immediately. This is circulatory overload, which means too much volume in that child. Honestly, the most I've ever seen in reactions is fevers. And that still is a reaction. Again, stop it, notify the healthcare provider. Your priority over is to stop it. Sickle cell anemia inherited by parents, African American, 25% chance of getting it with both parents that have the trait. Thalassemia, Cooley's anemia, which is the worst of all the thalassemias. Again, this is from the Mediterranean people. And all it is there's these square-shaped cells, and they die quickly and burst into the volume of the blood system. But when they burst these cells, what's inside? Iron. And a lot of them are bursting. So you're going to go into iron overload, okay? So your body's producing cells, they're dying quicker than they can produce them, and you have iron in your system. So what are you going to see? Chronic hypoxia, and they're going to need something to get rid of that iron that's been spewed into that blood system. And aplastic anemia is white blood cells, red blood cells, and platelets. They're all not working enough, and this is that bone marrow that's not doing it. So sickle cell, inherited, like I said, and this is the problem with sickle cell is when you go into crisis. So crisis can be due to infection, stress, many different things. Dehydration is one of the big things that can happen. So you get a child in complaining of severe pain, let's say in the knee, or even the chest is probably one of the most common that I see. So what happens is this blood is flowing and it's coming down and it goes to bifurcation and it blocks it off. And the cells pop behind it. So below, you're not getting blood. And above, the blood keeps coming, so it stretches and it, causes swelling and all this pain. So how are we going to treat? What is priority? Well, these vessels are small because this body's dehydrated. We need to dilate those vessels to let the blood flow and treat the pain, okay? So now we're treating the cause of the pain first. We're gonna give a bolus of fluid, number one. That's number one that we do for these children. Bolus that and get the blood flowing and give the pain medicine at the same time. And apply some heat, causes vasodilatation. So now the vessel's open, it's been dilated with fluid, dilated with heat. Now these sickle cells can flow, the swelling can decrease, and the pain can be decreased too. And, sickle cell, again, is one of those that their cells are dying pretty quickly. So a lot of times their hemoglobin and hematocrit are low. So give them a little oxygen, and that can help, with their strength and their activity. So children with cancer, one of the things that we give is chemotherapy agents to kill the cancer. We know that there is side effects. And one of the side effects is that it can drop a patient's neutrophil count below 500. Well, what are neutrophils? What does this mean? Well, neutrophils are a white blood cell that helps fight infection. So if these levels are low, this child can become extremely sick because there's no fight in them. There's nothing to fight with. So good hand washing is number one. Now, when we give chemotherapy on day 5 of 7 on chemotherapy, this is called the nadir period. And this is when those neutrophils are even at the lowest. So as a nurse, what does that mean to me? I'm going to be very careful, okay? Because this is when you're going to start seeing, the neutrophils the lowest, and that we really need to be careful. Leukemia. Leukemia is a cancer of the blood-forming cells in the bone marrow. And it's an unproliferated production of immature white blood cells, which means they don't work good. They're not going to work well at all, and they are cancer. So what do we do? Well, we're going to be given an intense beginning of chemotherapy. The first 4 to 6 weeks, we're going to be given 2 or 3 different types of chemo, no matter what it is. And we're going to be giving them a lot, which our goal is when we want to get rid of it, we want completely to eradicate all of the cancer within those first 4 to 6 weeks. Now, after that, there's other stages where there's a couple little cells and to be sure that it's gone, but we want to put them in remission. After the first 4 to 6 weeks, that's what we want. Now, we're going to continue with chemo, but our goal is to really get them at first. Now, chemo does cause nausea and vomiting, so antiemetics 30 minutes before. Osteosarcoma is a tumor of the femur. It's that long bone. I see it a lot in those teenagers and a lot of males. They start complaining of pain or they're limping, swelling, something's going on. It progressively gets worse. And then they go look, do an x-ray, and they see that there's cancer there. What is the treatment? Well, we need to remove the femur bone. Now, years ago, we just take off the whole leg. Today, we salvage the lower limb and put it up into the hip joint. And why do we do that? It seems like, well, the foot's going to be there. Weird. No, you have a place to put a prosthesis, and it's more secure, that these children are more secure balancing with this prosthesis, and it's more comfortable. So in osteosarcoma, there's chemo, and then there's, the surgery, and we do everything possible to salvage that limb. Now, in leukemia, sometimes we need to do a bone marrow transplant. Chemo's not working, so we have to do something. So there's 2 different types of chemos we can do. We can do autologous, which means it came from me. Could be, a smaller child, because these are young children, 2 to 5, boys. This is normal ages for, you'll see cancer, leukemia. So they still could have their stem cells. So autologous would be their own stem cells. Allogenic could be from other person than themselves. Now, the good thing about bone marrow, it doesn't have to be a relative, doesn't have to match anything, but we know that the allogenic coming from the siblings is one of the best matches that we can do, but it doesn't have to. So autologous, automatically it's mine, autologous, and allogenic is from somebody else. What they do is they wipe the whole immune system out, and then they'll put the bone marrow transplant in. Brain tumors are part of children and what happens. And usually what we'll see is a child that starts with a headache, and they might vomit, but there's no relationship to when they eat or anything, or they've not eaten and still vomiting. But their headaches and vomiting continue to get worse and worse and more frequently. So a headache here and a vomit here, nothing. But you start seeing it every day, several times a day, getting worse. Headache is now, you need more than Tylenol or Motrin. Something's going on. They'll go for investigation. Lymphoma in children. Now, there is Hodgkin's and non-Hodgkin's lymphoma. Now, the most, I think the easiest to see of those is that non-Hodgkin's lymphoma. And what we see is in the upper area, above, the shoulders, cervical area, you're going to see that neck with a big nodule. And you're going to say, doesn't that hurt? And they're going to say, no, it doesn't at all. Painless, non-tender, movable nodes. This is non-Hodgkin's lymphoma, and it's pressing against the airway, so you might even see that cough. So Hodgkin's is that non-painful, and non-Hodgkin's is when we're going to see that there is all sorts of spreads going on. So Hodgkin's is that node that's painless, and you'll see Reed-Sternberg cells, and non-Hodgkin's is more of a diffuse, okay? So Hodgkin's is just the lymphoma. Now, you're gonna have 5 dosage calculations, very similar to the last exam. Just study them. If you want a worksheet, I have one. Ask your professor. I would be more than glad to send it. And I do have a YouTube channel, which has dosage calc. Make it very simple for you. If you want to review it with me. It's about 45 minutes long if you'd like it. So Professor Bogart, Pediatric Nursing, you can find it there. So thank you all for coming. I appreciate you.
Did you
I
send?
wish, yes,
Thank you.
Thank you.
you're welcome.
Professor Bogart,
Yes,
would you send your Kahoots to Professor Morris?
absolutely. Absolutely. I plan with my recording to send the Cahoots with it so everybody has it also.
Okay, thank you.
My